All right, you guys, we're gonna jump back into another video here. This time we're talking about the upper airway, but I just have some miscellaneous points that I wanna get into to make sure that we hone in on these things as you are understanding the upper airway. So let's jump into those. All right, you guys, so as we finished up the oral cavity, we have another little, let me do a grab all for kind of this miscellaneous, these points I want to make sure that we emphasize so that we get these points, because these are some of the key takeaways that we need to make sure that we are not missing. So let me just make sure that we cover those right now. So when we are looking at the anatomical structures of the sternum, when we look at this, we need to make sure that we are looking at the manubrium, the sternal body, and then the xiphoid process. The area where the sternal body and the manubrium come together, this is what we call the angle of Louis. The angle of Louis, again, is a key anatomical site for where antecarina is. The carina is where the left and the right main stem bronchi separate. So this is where the trachea splits into two separate airways right behind the angle of Louis. It also gives us insight as to where the second intercostal space is, because we're going to find that angle of Louis, and then the intercostal space that's just below that is a key anatomical feature for needle decompression and for some chest tube sites. This is a critical site that we need for emergencies. So again, the manubrium connects to the sternal body. Right where that connection is that angle of Louis. The carina is there, and it also gives us insight as to where that second intercostal space is. Moving into our next area here, or our next idea that we have to get, is when we look at the ribs, we have what's called the costal ridge. This costal ridge, this ridge that is right below, that's right below each of the ribs, is an area that houses the vasculature and the nerves for this area. So you get your veins, you get your arteries, and the nerves that are on this inferior border of each rib. And that is important because we learn that in those emergency situations with a pneumothorax, we have the ability to do a needle decompression, and to remember that we need to do the needle decompression above the rib, so that we don't run into any of that vasculature or the nerves running below the ribs. And here we see that with patients with COPD, they often use accessory muscles to assist with their flattened diaphragm. And that happens because they struggle getting air out. They have what's called an obstructive disease. And we know that with obstructive diseases, they struggle getting air out. So they are what we call CO2 retainers, or they hang on to additional volume that's in their chest. And what happens is their AP diameter, their anterior posterior diameter, ends up getting bigger than their width of their thorax, and we call that barrel chesting. And when that happens, we also get a misformation or a change in the thoracic cavity, where the diaphragm that usually has this arch that's here ends up getting flattened because of that extra air that's in the airways. And with that flattened diaphragm, it does not have the ability to move down as we know it needs to in order to get air into the lungs. So what ends up happening is we see patients that need to brace their elbows against the arms of a chair so that they can stabilize their shoulders and utilize accessory muscles like the pecs, like the sternocleidomastoid, like the trapezius, the scalenes, the external intercostals. All of these muscles we use to try to get air in. And then muscles that we try to use to get the air out are going to be all of our abdominal muscles here, along with the internal intercostals to try to get air out. So when we have COPD patients, they have a change in their anatomical makeup with that increased AP diameter, flattening their diaphragm, so they need additional muscles, these accessory muscles, to try to get that volume in, and they need assistance to try to get that volume out. So lots and lots of different muscle groups that are involved with simply breathing when it comes to our COPD patients. So if you're utilizing a bunch of different muscles, even if you were working out, what do you think your nutritional intake is going to be? It should go up, right? You're increasing your metabolic demand, you're working your muscles even harder, so you should be increasing your nutritional intake. Well, with COPDers, we see that they're breathing so hard that it's like they've been running a marathon all day, yet they don't have the same nutritional intake because it takes so much effort for them to breathe. So we start to see more of a frail body or a cachectic body frame with our COPD patients, especially our emphysomatics. So when we talk about what it takes for a patient to generate a cough, this is an explosion of air that comes from the alveoli and the respiratory zone that's exploding out of your tracheobronchial tree to then remove secretions or to get rid of a foreign body or a stimulant or an irritant has triggered this reaction. So in order for that to happen, there's got to be a tight closure of the larynx to build up the pressure in the intrapleural cavity, or the intrapulmonary pressure has to increase through muscular effort. So the diaphragm is going to drop even lower than it normally does. We see with quiet breathing, it's about 2 to 3 centimeters, but this thing can drop as far as 10 centimeters or more to generate a bigger cough or to try to get more intrapulmonary pressure. And it's necessary to generate even like a shout or a yell or a cough or a sneeze, something where we're trying to explode and get that intrapleural pressure really high, get that gradient, the difference between your intrapleural pressure. You want it at rest, it'll be quite small, and then in this moment it'll increase, and then you have this big explosion and change in those pressures that lead to that cough or sneeze or even a yelling. You have closure of the false and true vocal cords, and what ends up happening is you get that intrapulmonary pressure to increase, and it can increase to greater than 100 centimeters of water, and compression of that expiratory muscles lead the abdominal muscles. You have the internal intercostals. All of those then come together, boom, creating that explosion with that sudden opening of the larynx to immediately release that high amounts of pressure that have been built up, and you end up with that cough or a sneeze. So again, there's some sort of irritant or some sort of stimulant or foreign body that's in the tracheobronchial tree or the nasal or oral cavity somewhere in your airway that's creating the desire and the need and the want to get rid of that stimulant. In order to do that, you have to get this large intrapulmonary pressure. It can be greater than 100 centimeters of water. And with doing that, you have the larynx closure, you have the true vocal cords closing, you have the false vocal cords closing. And then you get the abdominal muscles and the internal intercostals all working together to then squeeze all of that extra pressure that has been built up in the in the thorax to then squeeze out and explode out to generate this cough or this sneeze. So what happens when you have an artificial airway? When you have an artificial airway that maintains an opening in the glottis or an opening between the vocal cords, you don't have the ability to generate that big intrapulmonary pressure. So then you don't have the same amount of explosion that you would with that larynx and those true and false vocal cords coming together to close. So this is why at times it's difficult for our patients who have an advanced airway to generate a strong enough cough to remove those secretions. And that's why we have to go down and suction those patients if they cannot get those secretions out themselves. So when we look at this, the cough is a mechanism that consists of a stimulation, a deep inhalation, a contraction, and an expulsion or an explosion, and loss of effective use of abdominal muscles result in marked inability to exhale forcefully. This is a rule of thumb in EGANS. So let me go over that again. This is a rule of thumb in EGANS. So in order for a cough to be generated, the cough mechanism consists of stimulation, deep inhalation, contraction, and explosion. Loss of effective use of abdominal muscles result in a marked inability to exhale forcefully and cough effectively by affecting steps 3 and steps 4, leading to retained secretions, atelectasis, pneumonia, and airway collapse. So when we have, or if we have a patient that has abdominal muscle fatigue or paralysis, this is going to totally impact that patient's ability to cough. It's going to impact their ability to create that contraction and that explosion or that expulsion of those secretions, leading to retained secretions, atelectasis, pneumonia, and airway collapse. The last thing here that we really want to look at is maintaining a patent airway. So when we look at the position of the oral pharynx, when we look at the position of the oral cavity, the pharynx, and the larynx, crucial upright airway patency of an unconscious patient is key. So we want to make sure that when we have an unconscious patient that we have them in an optimal position to keep their airways open. Upright subjects that are sitting up, perhaps on a gurney, or if we come across somebody at a trauma and a wreck and they're sitting in the chair, the head has a tendency to flex. So when we have that flexion of the neck, what happens to the airway, especially right here at this right angle? Yeah, it gets closed down, it gets squashed. You decrease the ability for airflow to come in and out of the tracheobronchial tree. When we have those patients that have loss of consciousness, that head tends to flex forward, decreasing the angle of the airway, leading to either a partial obstruction or a complete obstruction. And what we want to do is we want to extend the lower jaw. We want to extend the lower jaw by grabbing the lower jaw and pushing it forward while we increase them into a sniffing position. What this does is this creates a direct line and a patent airway that's wide open, or it will alleviate that obstruction. By pulling the jaw forward, by grabbing the jaw and pulling it forward, what that does is it will that extension moves the tongue away from the posterior pharynx, and that maintains the airway of an unconscious patient and facilitates optimal airflow in and out of the upper and lower airways. When we have patients that have a C-spine injury or a cervical spine injury, even if it's suspected, the airway must be opened by using a jaw thrust. We cannot tilt the head back because that potentially creates, can cause a broken neck or fractures or create paralysis from severing the cervical spine. So we must be proficient with creating that jaw thrust. The way to do this, I'm going to read this directly from the book. This maneuver is performed by placing the index and middle fingers behind the jaw angle. So we're going to grab back here behind the jaw angle right here, and we're going to pull it forward. So we're grabbing the jaw angle and we're pulling it forward. This maneuver is performed by placing the index and middle finger behind the angle of the jaw and physically push the posterior aspects of the mandible upwards while the thumbs push down on the chin to open the mouth. This movement will move the tongue forward and relieve the obstruction. So not only do we need to be proficient with getting patients into a sniffing position to open up this airway, but we also need to be aware of patients that have or are suspected to have a cervical spine injury so that we can take our index finger and middle finger and push that forward. At the same time, we're going to push down with our thumbs to open up the mouth. What that does is that moves the tongue forward from the posterior oral cavity and will help alleviate any potential obstruction. So these are about 5 or 6 key elements that we need to make sure that we have down when it comes to the thorax, the oral cavity, the accessory muscles. All of those are super important when it comes to assessing the patients that we will be managing. Thank you guys so much for joining me as I talked to you about some key points that I wanted to emphasize with the upper airway. Be sure that you remember that learning is a journey. It's a process. So give yourself some grace if you're not figuring this out with the first time that you've heard this. Go back and watch it again. Listen again. Maybe there's a key point that you didn't hear the first time that you get the second time. So remember, we're always striving for progression. We're never going to get perfection. Stay focused, stay determined, and as you are getting this information, just know that it is going to impact how you see and how you develop yourself to be the practitioner that you want to be. If you liked this video, be sure to hit that like button, hit that subscribe button, share this with one of your friends, leave me a comment, and if you want to get some tips and tricks even sooner, hit that notification bell. Be sure to follow me on all of the social media platforms. I've got Instagram, TikTok, X, LinkedIn, Facebook. You can reach out to me personally to my Gmail at jjthert@gmail.com. Looking forward to seeing you next time.